Hello, and thank you for joining the Donut of Destiny. This special episode is sponsored by GE Healthcare. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
GE Healthcare is glad to be the sponsor for this episode of the Donut of Destiny podcast. GE Healthcare is the leading global medical technology, pharmaceutical diagnostics, and digital solutions innovator dedicated to providing integrated solutions to make hospitals more efficient, clinicians more effective, therapies more precise, and patients healthier. Learn more on our CT solutions on the GE Healthcare website.
Hello, listeners, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. Today, we have another industry-sponsored episode that will be adding to our Building a Cardiac CT program series. In this episode, we will explore the creation and growth of a cardiac CT program at a community hospital system in Louisiana. We are joined by Dr. James Parker, a cardiologist who practices at North Oaks in Hammond, Louisiana. Dr. Parker did his medicine and cardiology training at LSU in New Orleans and has been in practice for over 14 years. He has been an integral component in the establishment of the cardiac CT program at his practice, and we are so excited to have him on board to share his expertise. Jim, welcome onto the podcast.
Thank you. Thank you for having me.
All right. Before we get into the topic at hand, I want to learn a little bit more about you. Where are you from? What's your current role in your practice? And can you describe perhaps your journey through cardiology and cardiac imaging?
Absolutely. Well, I'm a native of Louisiana. I grew up in New Orleans and LSU. Go Tigers.
Go Tigers.
And did all my training at LSU. Actually survived Katrina through my training, which was quite a challenge as well, too, and kind of opened our eyes a little bit in terms of practice, the shape of things later on. I've been in Hammond now, which is just north of New Orleans. It's about 40 miles north of New Orleans, actually. So just a hop, skip, and a jump. We're a rural community hospital, but we're actually a fairly large hospital. We're a 400-bed hospital, actually. So even though we're in a rural area, we've actually kind of grown to a fairly large establishment, and we're pretty much the only hospital in a very large radius that take care of patients, especially from a cardiac standpoint. Most of my partners, I've got actually 4 other partners with me. We're all interventional cardiologists. And so we've spent most of our time in the cath lab as opposed to other imaging modalities. CT is actually somewhat of a new venture for us to some extent. We've had CT here at the hospital for many years, but we didn't do much in terms of CT coronary angiography. We're a level 2 trauma center, so a lot of our CT time has really been used by others, and we didn't have much of a role on our CT scanner in order to do CT coronary angiography until recently. Why the shift occurred using more CT at this point, I guess it's also been a shift, of course, by the guidelines that we've seen. Number one, showing how much benefit there is from CT and even over other functional studies, including nuclear and everything else. The other thing, too, has been a shift in terms of the insurance companies really preferring to have CTs over nuclears, mainly because of the cost. And I guess that was one of the things that we had to start examining when we were getting turned down trying to do diagnostic testing on our patients. We said, okay, well, what else can we do? We don't want to cath everybody. I don't want to be invasive all across the board. What else can we do? And so that's when we started to look into CT. And I ended up doing my CT training with Dr. Matthew Budoff at UCLA, who's, the guru of coronary CT, actually. And that's also where I was exposed to the GE 256 slice scanner, which was just wow. I mean, looking at the images from that thing, as opposed to our 64 slice scanner, was really revolutionary, really incredible. And I think that set me off on the crusade of, well, we need one of those. And we need a dedicated program to start doing CTs and to be able to serve our community with CT angiography, which is kind of where we've come to now at this point.
Fantastic. I think you've given us a good pulse on what the environment was like immediately before and as you were starting cardiac CT in terms of the cardiovascular diagnostics, particularly with some of what I think many of our colleagues have experienced around the United States with denials for other diagnostic tests, including nukes and diagnostic CATs for the evaluation of cardiovascular diseases. So with that in mind, you described the creation of a dedicated CT program. So I presume that the space that you had before for performing whatever cardiac CTs you were doing was a shared space with other imaging services. Can you talk about that transition from the shared imaging space to a dedicated cardiac CT space? I know many out there may face similar challenges in how to justify not just to the budgetary leaders, but also those in the community, other personnel, and space requirements that are needed for creating a dedicated cardiac CT scanner relative to sharing space with one that's used by other imaging service lines.
Absolutely. I'll be honest with you, it was a hard sell. It was not easy to do. We were using our hospital CT scanner was the main place that we were doing, even our outpatients, we were doing them in the hospital, of course, and that's obviously a shared space. The problem with that was obviously justifying the costs. And one thing that we had to show was that number one, CT was going to be a growth industry, especially as compared to how many we were doing at that point. But also from a personnel standpoint, one argument I was able to make with our administration was that prior to having the 256 scanner and being able to, really dedicate time to that, we were kind of excluding a lot of patients. We couldn't do patients with atrial fibrillation. We had to have very good rate control with heart rates. And, again, even then, the image quality was not always amazing, because you just have a lot of registry artifact and everything when you're trying to rebuild those pictures. And if there's any variability to the heart rate, it just really makes studies very difficult. On top of that, we also needed to have a nurse that was there in order to administer IV low pressure or whatnot to actually help control the heart rate. And with the new type of scanner using perspective gating, we're able to show, number one, we can reduce the radiation dosages drastically as compared to the old scanners with the level of clarity, the penetration and everything. Because, I'm sure your population is sort of like my population. BMIs less than 30 are a rarity. Even less than 40 is a rarity, as a matter of fact. The new scanners obviously are going to open up the doors to having better image quality on your patient population, as well as being able to even weight base your contrast doses. So you can even decrease your contrast amounts, which obviously a big thing out there right now too is just acute kidney injury from contrast. So being able to show that, one, we can reduce our dosages, reduce our both with radiation as well as contrast. We don't have to worry as much about the heart rate. Obviously, still using the oral beta blockers are still very important. The slower you get the patient, the better the images, but that heart rate becomes a little bit less of a problem with these faster scanners. Therefore, we didn't need a nurse with that. So that was staffing wise. They were really happy about that. They said we could maybe do this in an outpatient setting. We don't have to have a nurse there. We can actually do this with our radiology techs. Again, still buying a multi-million-dollar machine, it's still a hard sell, but I think when we actually finally showed what the growth was going to be, and then also to the amount of denials that we were getting with using other modalities, especially nuclear, we mentioned about the cost. I looked at the cost even several years ago. A nuclear stress test is still almost twice the cost of what a CT coronary angiogram is. And insurance companies know that. And so they are definitely more apt to approve that CT scan. And even with the guidelines, it's a very, very good tool in terms of looking at your even low to moderate risk patients who just have that nagging chest pain and still have risk factors. And what do you do with those folks? So we said, I think this is a good avenue that we can truly serve the public, that we can do it safely, that we can do it more efficiently. We showed how much faster this scanner was so that we could get patients in and out much faster. The volumes would be higher. And, and it still took a couple of years of wrangling and making those arguments that they did finally come on board. And I think at this point, I know that they're very happy. In fact, we're now adding a 256 scanner to our hospital. So we placed ours in the outpatient setting. We actually still have the old machine in the hospital for everything that they do in the hospital, but now the majority of our CTAs are all done as outpatients. And we have an outpatient diagnostic facility, which is where we put the new scanner. So that's our main modality of doing it currently. But they are in fact now adding a 256 in the hospital because I think they've seen that value, and I think they've seen that growth and where the program can go, which is extremely exciting.
I mean, Jim, that's a huge success story, right? Like these machines and the personnel and other resources that they require are not insubstantial. So to be able to compel our colleagues that are in administration to understand some of what we're trying to provide to the community and be able to do that now twofold is such a great success for your community. So super kudos on that. You talked a bit through how you selected hardware and your experience with certain hardware platforms. I wanted to get a little perspective on how you approached software selection, because as we know, a lot of cardiac CT post-processing requires some heavy-duty software, and that is not an insubstantial component of budgeting for these types of programs too.
Well, we already had the GE software, which is what our radiologists were using to read CT scans just in general. And so we just started using what they had, and it's been great. I actually, again, that was part of my training was to learn the software and everything, and it's a fantastic tool. I know there's a lot of other different softwares out there. In fact, right now, our radiology department has in fact made a decision to go with a different type of software, which we've not put in place yet. So I can't really speak to how it's going to go, but we are changing softwares towards the end of the year. I've yet to play with it, so we'll see how that goes. Obviously, we've all become comfortable with what we're doing. Obviously, as the software evolves, there's more AI with the software. It's trying to do things very automatically at this point and draw everything out for you and kind of do a push button approach. I still am a little leery about that. I'm still waiting to see how that goes, because as great as the software is, and even the GE software, has that capability on those perfect studies. Oh, it'll draw everything just beautifully, but all those studies are not perfect, and a lot of times you've got to go in there and manually do things. So we'll see how that goes. Like I said, it wasn't really our decision from the cardiac standpoint to change software, but our hospital has decided to change software at this point, and we'll see how that goes towards the end of the year. But fingers crossed. Fingers crossed.
Okay, excellent. And I think you touched on a topic I want to explore a little bit more now is image quality coming in, right? You want to get the best quality images coming in. We know how challenging that can be in our patient populations, but that ends up allowing us to provide the best quality reporting and therefore best quality patient care on the other end. So you described a bit about your workflow for preparing patients for and then actually performing image acquisition on the scanner, including how you approach beta blockade or rate control, how you approach vasodilation with nitroglycerin, and actually the absence of nursing staff in your outpatient setting. Could you perhaps break that down a little bit more, flesh out the experience of a patient when they first arrive to the CT scanner, what they're going to go through, who's involved from the personnel side, and how the images kind of get acquired and pushed over to y'all to read?
Absolutely. Well, I'll tell you, we've finally found some tips and tricks essentially over time. The way we were initially doing our CT angiography was we would do a test bolus, and then that's how we would acquire our timing and then do the actual scan itself. That's how we did it on our 64 slice scanner. One problem we always had with that is when the patient would get that initial test bolus, they'd freak out. They get this hot feeling, and all of a sudden, now your heart rate jumps. And with the new scanners, and when I went to UCLA and saw how they did this stuff, they used the auto trigger. Essentially, they just it measured the Hounsfield units and said, okay, go ahead and start acquiring the images rather than doing that test bolus. And I think by getting rid of that, by the time the patient actually feels that dye hit them, you've already acquired the images. So you've got more stability in terms of the patient, their comfort as well too. One thing as well, we still use the beta blockade. We still use oral beta blockers. Our practice is to give a prescription for 50 milligrams of low pressor. We just give them 2 pills. I tell the patient 4 hours prior to having your scan, check your heart rate. And if it's greater than 60, go ahead and take 1 pill. And then an hour prior to the scan, check it again. If it's still greater than 60, take the other pill. And that usually controls everyone fairly well, that we don't really need the low pressor IV push any longer, which again eliminated the need for the nurse, which was a cost savings. One of the other things, and I've already had a CT scan done on our old scanner back when, so I knew what they were going through even before we changed our protocol. We would use sublingual nitroglycerin. And I know for me, the tablet never actually dissolved. You're NPO at that point, and you haven't had anything to eat or drink. Your mouth is dry. So a lot of times that was fairly ineffective. We ended up deciding to change to spray nitroglycerin. So at that point, you don't have to worry about that. It's instantaneous. It's going to absorb. It doesn't matter if their, mouth is dry or not. You're still going to get the nitro effect and not have to worry. And that's actually worked out really, really well. And actually, I got that idea from UCLA. That's what they were doing. They discovered that over time. They said the sublinguals just weren't working very well. They just weren't very effective for most folks. And so the onset was much faster with this, and it was definitely more controlled. So that's actually worked out well. One thing we also try to tell them is, make sure you hydrate the day before. Make sure you drink, a lot of water, because we tell them, we try to scare them into hydration for all intents and purposes. We said, look, if you come in dry, we have to start that IV, and we're going to be poking around a lot. So hydration obviously is really important in terms of just controlling that heart rate. So although they're NPO for the study itself that morning, I really want them to hydrate well the day before. And so we've tried to just really encourage them to just try to do that. And if we have to scare them a little bit, we kind of scare them a little bit. We're going to be poking with you at IV now, so make sure you're hydrated. So that's really helped out a lot too. Prospective gating has been, really fantastic as well too. We've been able to lower our dosage. Obviously, that works well if your heart rate is still reasonably well controlled and you're not in atrial fibrillation. Atrial fibrillation will do, we'll still do retrospective, which is great. But no, I think I have not had any complaints from patients. They've been very pleased how everything goes. It's very simple. It's very quick. People are in and out, really pretty fast, actually. And I think it's worked out very, very well at this point. We've also, again, with our patient population, as we talked about BMI, there's always a balance trying to find the best penetration as opposed to the best radiation exposure, trying to keep those kilovolts down as much to take the grain out, but still being able to get that penetration. And we played around with those parameters quite a bit. We finally came up with some protocols, and we base it on their BMI initially, so we look at that. We see the patients when they're coming in the next day and essentially decide which protocol to use. Most of the time, the auto protocol works, but for some of our much larger BMI patients, we've designed some protocols to be able to get that penetration and still keep the radiation exposure and that granulation artifact to a minimum, and try to find the balance between the amps and the kilovolts as well too. So.
That's awesome. I mean, it's great hearing about the well-oiled machine that you've helped build over there. You had mentioned it's around 700 to 800 exams or so per year that you've expected and are probably going to continue to grow. Could you talk a bit about the case mix? Is it all coronary exams, or are there things beyond that y'all are doing?
Those numbers are just our coronaries. Now, we also do CT angiography for carotids, because we do carotid stenting and everything here. We're using the CT scanner a lot more rather than doing conventional angiography for that at this point too. We do TAVR. So we have a structural program as well. So we do CT TAVR as well. So obviously that's looking at peripheral, it's looking at the valves and everything too. But no, those are the 700 to 800 exams actually at this point are just coronaries. So yeah, we do have the other modalities as well that we're using this for, and we're still trying to expand our structural program. We're looking at mitral clip and everything as well too. So we'll be using it for that. So yeah, hopefully bigger and better as we keep going.
Fantastic. As you've mentioned, you're doing really whole body imaging there, because as part of the access evaluations for your structural work, you're going to be acquiring things beyond just the heart. So I'm curious to know how y'all approach the interpretation of the non-cardiac findings on the images that y'all acquire.
Absolutely. Well, so we pair with our radiologists. So essentially, I'm responsible for the coronary aspect, and even with TAVR, we'll do the vascular aspect as well too. But anything aside from vascular, we pair with our radiology colleagues, and they give us the overread for everything non-cardiac at that point. So we get both reports. We're able to see that, and we talk to each other just fluidly. They'll say, "Hey, look, I saw something kind of weird. Maybe we better check this out a little bit further." And I'll jump on that. I'll get them to our pulmonologist. I'll get them to our GI guys. I'll get them to whoever we feel like need to take a look at this a little bit further. But no, it is. We don't want to miss anything. We absolutely don't want to miss anything. They're a lot better at reading that stuff than I am. So I know my limitations. So I defer to those guys. Absolutely. That's crucial.
Well, it's great. It sounds like you have an excellent working relationship with the radiologists who remind me, are they also part of the same hospital system?
They are. We're actually all hospital employees. Yeah, we all work for the hospital itself.
Got it. Okay. Well, that brings us to an interesting question then. If you are within the same hospital system, perhaps you can track some of the halo metrics or the downstream effects of building your cardiac CT program. Could you talk to us about some of the downstream effects you've seen with the growth of your cardiac CT program, perhaps with a focus on cath lab volumes and workflows?
Absolutely. Well, as an interventional cardiologist, I've seen it firsthand. I've seen it in my own practice, and actually, and I've talked to several of my partners about this too. One thing we have seen certainly is a reduction in our diagnostic caths, mainly because we're ruling people out that we otherwise probably, felt needed something more than just a basic stress test. You had an inconclusive stress test and said, okay, well, the next thing we would have done was we would have brought them to the cath lab, and now we have another modality to do this, and especially for patients that we still feel are fairly low to moderate risk, but just feel like we need something a little bit more, not invasive, but more intense, need something that's a little bit more concrete. CT has definitely filled in the gap for that. So, I know personally for me, I would say that my diagnostic coronary angiography numbers have dropped by half. And I've heard that from several of my other colleagues. I'm spending more of my time in the cath lab now fixing things rather than just going to look. And what we found too is I think our correlation at this point with the CT angiography has been, I'd say, somewhere around 70 to 80% accurate. And in fact, I would even say that we're probably getting after disease that we would have otherwise blown off before. One limitation as an interventionalist, one limitation that we have with coronary angiography is I can only see what the dye shows me. So it does not tell me necessarily about the soft plaque burden. It does not tell me about diffusely diseased arteries. In the past, we've looked at it and said, well, I think the arteries are just small. Oh, it's a diabetic patient with small arteries. Now, with the advent now of IVUS, intravascular ultrasound, which gives us a lot of those same images that we're going to get with CT angiography before we get to the cath lab, we're now realizing those are not small arteries. They're just really heavily diffusely diseased arteries that we probably have been undergrading for a long time. And that's one thing that has really pushed me a little bit more when I have a CT angiogram and I know what I saw on that CT angiogram and I bring them to the cath lab and I'm looking at that angiogram saying, this doesn't look as bad. I still have that. I'm going to go a little further. I'm going to look a little bit harder. I'm going to maybe do IFR or FFR on that patient and say, I want to be sure. And 9 times out of 10, that CT scan was right. That angiogram was a little misleading because it's more diffusely diseased than we thought. And I think it's led us to actually now treating things that have really gone untreated. And it's not that we didn't want to do the best job we could. We just didn't have the tools or just really angiography is it's a great tool, but it has its own limitations like every other modality. And I think CT has really, really paired, certainly as an interventionalist, has paired amazingly well. And I feel like I'm now doing a better job as an interventionalist because I have CT rather than it taking something from me as an interventionalist. I think it's added. And I'm also not spending as much of my time doing diagnostic coronary angiography because, the cath lab is at a premium as well. You've got to justify your staff. You have to justify the cost of each of these cases and the time it takes. Your schedule is you can only do so many cases a day. So to not burden yourself with simply diagnostic cases and to really get down to the nuts and bolts of the folks who need you to be in there and need that treatment, I think has been amazing. And it has not decreased our volume. If anything, I think it's probably increased our volume simply because I think we're discovering things now that we just have not seen before. To me, I think it's been a absolute win-win. It's been huge. As an interventionalist, I think it's been one of the greatest tools that we've had, honestly.
Jim, that's so fascinating. You're talking about the incremental value that CT is bringing to your cath lab processes, most notably bringing extra information about how to approach complex disease that may have otherwise been, if not overlooked, treated in a different fashion in the lab. That is absolutely fascinating, especially in the face of some of the fallacies out there that when you have more CT, you lose cath lab workflows, you lose cath lab productivity, which doesn't seem to be the case at all from what you're describing. You're actually talking about a synergistic relationship between the two. Super, super interesting. Could you mention anything perhaps about the other non-invasive diagnostics, for example, nuclear cardiology, MRI, other things that may be happening at your institution as well?
Sure. Unfortunately, we don't have cardiac MRI here. We still have to offload those to other facilities. I'm hoping in the future to have that, but unfortunately, we don't have that yet. Nuclear, as we talked a little bit before, has also been obviously those numbers have gone down. I don't want to say necessarily because of the CT scans, but I think really more just because of the environment. Nuclear is more expensive. Insurance companies are not approving it. They're harder to get at this point. Nuclear is also something you kind of have to plan for. You've got to know how many doses you need. And you can't really add a patient on that day, and it's not been as easy to use. Also, certainly within the hospital, when you have a patient that comes in, you say, really like to check this patient out today, but you can't add them on the same day. They're going to have to stay in the hospital longer. Whereas, as long as I can control their heart rate, I can get a CT scan on them. I mean, and their renal function is reasonable. I can certainly get a CT scan at that moment. It's a lot faster. So I think our nuclear volume, I know our nuclear volume has actually decreased a fair amount. I actually had reached out to my nuclear techs to say, hey, how are our numbers comparing right now as compared to a couple of years ago? They didn't get back to me yet. So I don't have hard numbers, but I know certainly because I'm the one who also interprets the nuclear stress tests. I'm not seeing as many. I'm definitely seeing more CT than I am nuclear. And again, I think it's for multiple reasons. It's really, I think the shift, the trend from a financial standpoint and everything too, and a feasibility standpoint has moved away from nuclear. And again, even acquiring the nuclear material has gotten harder. We have less places that are actually producing it. So we've got less generators out there now. So it is a lot harder. That's what we've seen sort of gone now are the days of thallium. We just can't get it. I mean, it's just not possible. So, I mean, I hate to say that nuclear is maybe on its way out. Controversial, because and I do understand the argument there as well too. One limitation obviously with CT is that it's not a functional study. It's an anatomic study. We can perform functional things as a post-processing aspect. We can do CT-FFR. We can look at some functional aspects, but it is not in itself a functional study. So, I mean, you're always going to have that that other argument, well, I know what the anatomy looks like, but is it hemodynamically significant? And I think it's an excellent argument. Maybe as our technology changes, CT will change and we'll have a more functional aspect to it perhaps down the road. So I think there's still some role, certainly for nuclear and other studies from a functional standpoint. But like I said, I think the current environment, it's just simply getting harder to get them. And I think we're seeing a decrease in volume for that reason, even there.
Jim, I think we've touched on some great topics thus far. I want to start bringing us towards the close of our conversation. And I know that many of our listeners out there have had your story resonate with them. It's something they're either in the process of trying to approach in terms of building a program, or something they've had in mind where they've met challenges along the way. Can you summarize a couple of pieces of advice for those out there that are interested in creating or building their cardiac CT programs at similar types of facilities?
Absolutely. When you're trying to build a program, and we've done this with many different programs, first off, don't lose your passion. Don't be dispelled that your administration's not jumping onto your bandwagon immediately. I've been in administration aspect. I've worn that hat myself. There's a lot of parts in play that we as the clinicians don't realize have to occur for something like that to take place. Bring them real numbers. Bring them data. It's not just about your excitement. It's about justifying that program. And I think at this point, there's enough literature out there. There's enough other folks who have done this that the data's there. Just simply present your data. Present the data that's there. The numbers do bear out, but it's still a hard sell. I mean, it's talk about a lot of money, honestly, and it's not simple. And just be persistent. It's not going to happen instantaneously. It didn't happen instantaneously for us. In fact, I've been really amazed at how fast it has happened. I expect it to take a lot longer. It was a little shocking to me, honestly, but I just kind of kept rattling that cage and just showing reasons as to why I thought it would benefit not only our hospital, but our patient population. And honestly, at the end of the day, your administration, no matter what you think of them, are still trying to take care of your patients. Patient care is still number one, and it is a balance between the two. Just show them that. I think that is the key, and I think they will respond to that. But just be patient. Like I said, the data speaks for itself. The numbers speak for themselves, and I think as the technology gets even better down the road, there's almost no way to argue not to do it. I can't see how anyone wouldn't jump into this program, just from a safety standpoint, from a usability standpoint, an ease of access standpoint, ease for the patient. It's just a win-win around the board.
Jim, thank you so much for joining us. It really was an absolute pleasure hearing about your experience building your program and your perspective from so many different components, from diagnostic cardiology, interventional cardiology, and from administration. So thank you so much for joining us. Really, really appreciate it.
It's my pleasure. Thank you for having me.
Of course. To our listeners out there, thank you as well for tuning in. Please make sure you rate, review, and subscribe to us when you can. This helps others out there find our content. So thank you once again for tuning in. This is the Donut of Destiny. Cheers.